Welcome, everyone. My name is Dr. Jeffrey Calvert. I am the Associate Director for Clinical Quality at the World Trade Center Health Program, which is a division within NIOSH and CDC. It's my pleasure and honor to introduce this 6th installment of the World Trade Center Program's Clinical Best Practices webinar series. Please note that all of these best practices webinars are being recorded, including today, and the recordings will be available on the World Trade Center Health Program website. To date, we have 3 webinars currently posted on our website that are available for viewing. Today's webinar is titled The Diagnosis and Treatment of Interstitial Lung Diseases. It will be presented by our well-regarded pulmonologist who has a long-standing affiliation with the World Trade Center Health Program. And he is Dr. Rafael De La Hoz, who is a pulmonologist, occupational medicine specialist, internist, and a professor at the Icahn School of Medicine at Mount Sinai. And I also want to recognize my 2 NIOSH colleagues who are kindly assisting us today with today's webinar. First is Kiana Harper, who's responsible for all of the technical aspects of the Zoom webinar. And second is Ann Riddle, who was assisting with the slides and will be reading the questions and comments that you submit. So please note that your cameras and microphones can't be used during this webinar. Instead, if you have questions or comments, please feel free to enter them into the Q&A window at the bottom of your screen. And hopefully we'll have time at the end of this webinar to answer any submitted questions or comments. Also note that live captioning is available at the bottom of your screen. And finally, we'll be offering continuing education credits for physicians, nurses, pharmacists, public health professionals, physician's assistants. And at the end of the webinar, I'll provide more details on how you can get those continuing education credits. Next slide. So we have a couple of disclaimers. First, the views expressed in this presentation are those of the speakers and don't necessarily reflect the official position of NIOSH or CDC. Mention of any trade names, commercial practices, or organizations do not imply endorsement by CDC NIOSH. And finally, citations to websites external to CDC NIOSH do not constitute CDC NIOSH endorsement of those organizations, and we are not responsible for the content of their websites. Next slide. We do have one disclosure from our speaker who wishes to disclose that within the past 24 months, he attended promotional programs hosted by AstraZeneca and GlaxoSmithKline, and as well as received a lecture honorarium from Teva Denmark, and all of these relationships have been mitigated. And next, we're going to do a couple of polls because we frequently get a question about who's the audience for these webinars. And we've had a difficult time answering that question. So we're hoping that you can help us understand who the audience is. So here's the first poll question, which is, what is your professional title? So we'll give you a moment or two to select your response. Okay, so half of the people are nurses, maybe about 20% are physicians or other public health professionals. Okay, good, thank you. And we have one more question. Who are you affiliated with? So the options are either one of the CCEs, Nationwide Provider Network, NIOSH, World Trade Center Health Program, another NIOSH division, or a part of the CDC or other. So we'll give you a moment to make your selection. Okay, so about 40% are with the CCEs, about a third are with the World Trade Center Health Program. Good representation from the NPN. Okay, so thank you very much. And so without further ado, let me hand the platform, the podium over to our esteemed speaker, Dr. Rafael De La Hoz. Take it away, Rafael.
Good afternoon, everyone. As you know, it's the title of my talk to present some guidance on best practices for the diagnosis and treatment of interstitial lung diseases. And I have to acknowledge my co-author on the article that we published as part of the series that includes all the major diseases. And it was published in open access. It's also available on PubMed Central. and Dr. Carol Johansson from the University of Calgary School of Medicine. And in a moment, you'll see why that is tremendously relevant. And I mentioned also that I have research grant support from NIOSH as principal investigator on a couple grants. I co-investigated on another 3 of them. Some support for clinical administrative work, and what Dr. Calvert mentioned, that my views do not represent endorsement by NIOSH or CDC. So this was part of a series of articles. As I said, they were very brief. They were published with open access in the Archive of Environmental and Occupational Health. And you will see all the references that I will provide, the PubMed ID, so that if you are interested, you can copy that. And practically all publications are available either open access or in PubMed Central. And as you know, these articles are also available at this site that Dr. Calvert also mentioned. So jumping right in, I'll start by saying that interstitial lung diseases is an umbrella term of a very large and heterogeneous group of disease entities that diffusely involve the lung interstitium. So by any counts, it's about 200 diseases, and some of them are extremely rare. And even the most frequent of them are not the most prevalent chronic diseases, but there is an important group of diseases. They are all frequently inflammatory and or fibrotic in nature, chronic and progressive. A subset of ILDs is idiopathic, with risk factors that, but no clear causal relationship with an identifiable exposure. So think of some of them as idiopathic diseases in search of a cause. And some ILDs are causally related with specific etiologies, including environmental, occupational, and iatrogenic exposures, as well as neoplastic and connective tissue diseases. So it's a very interesting group of diseases and very board eligible. Very tough questions come up in the pulmonary boards related to them. So and basically, I'm going to be citing this review by Marlies Vixenbeck and colleagues, very recently published in the Lancet. And basically, we have a number of environmental or other triggers, a genetic susceptibility, an activated immune system that initiates interstitial lung diseases. And given a persistence of the trigger, we think the disease develops, and either by the action of a number of injuries like infections, for example, and just by the very process of aging that causes changes in the lungs, you see these cycles of inflammation, and then through wound healing pathways, activation and epithelial damage that eventually move to the right here with extracellular matrix deposition and increased lung stiffness, and imbalance between profibrotic and antifibrotic mediators, and then the development and the evolution of from an predominantly inflammatory condition to a predominantly fibrotic process. And it is this progression, the one that is associated with most disability. So at the core of these diseases is the fibrosis in the lung interstitium that leads to 2 major effects. Not that these are the only ones, but a reduced compliance of the lung, so a reduced expansion of the lung upon air intake, and a reduced a gas exchange surface, because in the very delicate structure, there is a focus here of normal lung is very grossly broadened by inflammatory cells. All of these blue dots are inflammatory cells, and all these pink material is collagen from the fibrosis. So that's what's a common characteristic of these diseases that groups them together. So this again is relatively normal lung here, and this is very abnormal lung in an interstitial disease. So the ILDs have become an entity of patterns, and with the advent of CAT scans, we get very detailed images, and we tend to look at these different patterns as indicators of the potential disease that is going on. Surgical lung biopsy, it's a very cumbersome procedure with high morbidity and occasional mortality. So CAT scans have come to create these series of patterns that we try to match to diseases, and I'll delve into that. But as you can see, they have different distribution and characteristics that sometimes help us in discerning what type of disease is out of the 200 that I said or so that pulmonologists have to go through to try to figure out what the patient has. We have, many of you that care for patients may have seen this term of usual interstitial pneumonia. Realize that that was a pathology designation, a pathology pattern that with the advent of CAT scans became recognizable. And this is what we call a UIP, or usual interstitial pneumonia pattern radiologically, because as I said, I insist, originally it was a pathology, and it is still a pathology designation, and that in this case characterizes the case of idiopathic pulmonary fibrosis with the honeycombing pattern. This is what we look at here. The cystic formations here in layers. The traction bronchiectasis with the dilatation of the distal bronchi, and bronchiolectasis. This is a smaller bronchiole that has become very dilated by the stiffness of the lung and the fibrotic process, and the increased reticular pattern throughout, and some of the ground glass attenuation where there is increased density in the lung tissue because of inflammatory fluid. But in UIP, the predominance is for fibrosis, traction bronchiectasis, and reticulation, and honeycombing, and ground glass is less predominant. So here is the opposite, well, not the opposite, it's kind of related in non-specific interstitial pneumonitis. It just abbreviated as NSIP. You see the same features, except that the more predominant element is that of ground glass density, and the honeycombing is actually fainter, and the same goes for the reticulation. So that is the other another pattern that we try to recognize. And here we come yet with one pattern, an additional one, the DIP, desquamative interstitial pneumonitis, where ground glass is very predominant, and there are these cystic structures throughout the lung. This disease is associated with the smoking, and it has become much less frequently observed and described, but and it's usually seen in younger patients. So you see how we try to match these patterns and other factors like the age of the patient, the association with exposures, and to try to create a differential diagnosis. This is another ILD, is where we have these nodular lesions in the lung. They are centrilobular in location, and but there is no reticulation, and there's not much of honeycombing in this one, and there's a slight haziness to it, but this is a case of respiratory bronchiolitis, interstitial lung disease, which is seen in heavy smokers. And here's another pattern, the idiopathic pluriparenchymal fibroblastosis, where you see the reticulation in this case is very thick. very coarse, and it's also has a subpleural location predominantly, and these, and these very wide bands of fibrotic tissue, and this is another pattern that we look. So, anyways, in the back, as in the in trying to classify these diseases, I say there are like 200 of them. There are many classifications, but I thought that at very least you should think of them, about 5 major groups. Those that are exposure related, for example, hypersensitivity pneumonitis, occupational lung diseases, respiratory bronchiolitis ILD, the one that I showed you before in smokers, radiation or drug induced, and post-infectious. So we were just coming out of the brutal pandemic of COVID-19, and saw several cases of interstitial lung disease, some of them requiring transplant, just to give you an idea, and other infections can do the same. Then you have the autoimmune disease-related interstitial lung diseases, and including polymyositis and the ANCA-associated vasculitis, and the other connective tissue disorders that are associated with ILD. Lupus is one of them, rheumatoid arthritis, another one, polymyositis, etc. Then you have the ILDs that have cyst or airspace filling, and that includes lymphangioliomatosis, pulmonary alveolar proteinosis, Langerhans cell histiocytosis, and others. Sarcoidosis is a group by itself. I mentioned a little bit about that. Sarcoidosis is an interstitial process. It just has that granulomatous pattern that is so distinctive from the other ones. And then you have a number of idiopathic diseases like the ones that I mentioned before, interstitial pulmonary fibrosis, non-specific interstitial pneumonitis, desquamative interstitial pneumonitis, PPFE, and other that are maybe frankly unclassifiable. And realize that many times we, despite our best efforts and those of our multidisciplinary discussion groups, sometimes we don't arrive at a particular or final diagnosis. And then there is a group of others. There's always a group of others whenever a classification is not perfect, but this one is, as I said, practical enough, where we have the eosinophilic pneumonias, the malignancy associated ones. So being an occupational pulmonologist, I couldn't help but devote at least a mention to the occupational ILDs. And if you think of, again, going to, 5 groups of conditions, you have initially the inorganic dust, of which, where you have silica, coal, kaolin, milk, mica, sorry, talc, and other dust. We won't go into that. You have fibers like asbestos, the classic one. Then you have organic dust that are mostly associated with hypersensitivity pneumonitis, and realize that there are more than 300 of those reported in the medical literature. Then you have metals. First and foremost, hard metal is cobalt, tungsten carbide, and then beryllium, aluminum, and a variety of other metals have been all associated with ILD. And just to mention again, many post-infectious processes are occupational in origin. COVID was not an exception to that, just a reminder. And so that gives you the 5 major groups of exposures that you try to discern whenever you are evaluating a patient with an ILD. Blank and collaborators in this article from 2019 did a systematic review that I estimated at about 25% of what we call idiopathic pulmonary fibrosis cases are actually attributable to occupational exposures. So these are disease causal relationships that or associations that are often not realized in the clinical environment, and even in some epidemiological studies. The occupational ILDs usually have a very long latency period, which is the interval between first exposure and development of clinical disease. And That's characteristic of them. Some ILDs, such as IPF, are associated with cigarette smoking. DIP is another one. Respiratory bronchiolitis, ILD is another one. And in fact, they can sometimes coexist with chronic obstructive pulmonary disease, creating, for example, in the literature, you will see a COPD IPF overlap. The true epidemiology of ILDs is actually difficult to estimate because of limitations in disease ascertainment in many research studies. So we certainly made a case many years ago, and many others have, that the toxicant exposure at the World Trade Center or from the World Trade Center um, had the potential, at least, to facilitate the development or the progression of interstitial lung diseases. And we don't know exactly what agents are associated with that progression, if there is any. But we think that the irritant effect and the inflammatory effect could have that potential to do that. However, no study to this date has established in a definite causal link between World Trade Center exposures and pathologically and or clinically ascertained ILDs. However, because of the long latency of these diseases, we have the surveillance systems in place and we need further investigations, and they are ongoing in all the established cohorts that the established cohorts of the World Trade Center program. And this is how our surveillance looks. This is an example of a series that we published a few years ago, about 1,400 World Trade Center responders that had CAT scans. And this is their lung function trajectory. And in general, we know that the majority of people and the mean, the average decline in lung function over these many years of follow-up is about what would be expected in the general population. But averages are averages. So they include subgroups of individuals who are really declining in very steep manner. And we actually think that there are a subgroup that is actually improving, which is not increasing their lung function, which is not normal in adults older than 30 years of age, probably as a resolution of an initial injury on 9/11. So it is this investigation of these subgroup of individuals who are doing poorly where we are trying to identify what type of chronic disease, disabling lung disease is being developed. So the ILDs that are observed in the World Trade Center Health Program cohorts include practically all the most common types and clinical presentations that are observed in the general population. And I want this message to be loud and clear. We see just about everything that is seen in the general population. Because of that situation, we decided when the NIOSH launched its initiative of the best practices to identify a guideline that would be both recent and at the same time cover all of these fibrotic ILDs, because we are not just concerned with interstitial idiopathic pulmonary fibrosis. We are not only concerned with sarcoidosis, we are concerned with all of them. So the Canadian Thoracic Society, through a series of 3 papers that were published in these years, did exactly that. And they also met the quality requirements that were recommended by NIOSH, again, in this initiative. ILDs are associated with a high burden of symptoms, morbidity, disability, and early mortality, many of them. At the present time, there is no specific cure for practically any of these fibrotic ILDs other than lung transplantation. And while most classifications, of course, include sarcoidosis as an ILD, realize that sarcoidosis sometimes is a non-pulmonary disease. I have a patient in the clinical center, in Manzana Clinical Center, that has retinal sarcoidosis. So just it is it has its peculiarities compared to some of these other ILDs. But sometimes it is an interstitial disease with a granulomatous pattern and does lead to fibrosis. However, I just wanted to call attention to the fact that the treatment, the diagnosis and treatment of sarcoidosis is a little bit different. And although it's covering the Canadian Thoracic Society guidelines, on the other hand, there are more specific sarcoidosis related guidelines for diagnosis and treatment that were recently published and that have been endorsed by both the American and the Thoracic and the European Respiratory Societies. So after that introduction to these diseases, particularly for the non-specialists, what is the diagnosis and what is the role that clinicians in the World Trade Center Health Program play? Detailed assessment of symptoms, their nature, their severity, potential past and present toxic, occupational, and environmental exposures, medications, comorbidities, and their treatment. Because as I mentioned, some iatrogenic agents or factors can cause or worsen these ILDs. Family history, there is a family aggregation for some of the diseases, a complete physical examination, very detailed, and then in terms of testing, functionally, you go to a complete pulmonary function test that is including spirometry, lung volume determination, and diffusion capacity with bronchodilator testing to exclude any coexisting obstructive lung disease, reversible or fixed obstructive lung disease. So again, the hallmark of the ILDs for the most part is what we call restriction, and the definition of restriction is a reduced total lung capacity, and I'll emphasize that once again. A reduced forced vital capacity makes you suspect that restriction is going on, but you cannot consider it confirmed until you have obtained a total lung capacity, lung volume determination with total lung capacity. And the other characteristic of practically all ILDs is a reduction in the diffusion capacity, or DLCO, as I will refer to heretofore. So as part of the testing, I mentioned function. The other aspect is the high resolution chest CT with consideration of paired expiratory and prone imaging. And I hope I get a chance to explain why that is, but all chest CT scans are not made the same, and low dose CTs are not ideal, or in some academic centers, there may be sufficient expertise to diagnose ILDs based on low dose studies, but in the majority of the centers, you should really obtain a high resolution chest CT, and you might just go ahead and request paired and expiratory and prone imaging just to exclude other artifacts or give additional detail to the changes. And then it is recommended that collagen vascular disease markers be obtained, but most important is that the history of any of the symptoms that are characterized these collagen vascular diseases be assessed. Like, for example, arthralgias, arthritis, skin changes, rashes, etc. So, and eventually all of this information is put together and brought to a multidisciplinary discussion meeting, which is an often iterative process that initially decides whether tissue diagnosis needs to be considered. When a confident diagnosis cannot be achieved despite MDD review of all available information, that's when lung sampling procedures may be recommended. And transbronchial biopsy, cryobiopsy, or surgical biopsies are the three main types of tissue diagnosis. although dear to our occupational subspecialty, mineralogic lung studies have really not been integrated yet to ILD diagnostic protocols, but might be considered where available. For example, here at Mount Sinai, we have that capability. Interstitial lung diseases, here's a situation where this individual, yes, we have a pattern. And as you can see, if you can remember the images that I showed you before, it really doesn't look like EOIP, like usual interstitial pneumonia. There's no honeycombing or that I can really quickly find. There is not a lot of bronchiectasis or bronchiectasis, and reticulation is present, but it's not particularly marked. And there is some ground glass, but it's relatively minor. And yet this individual under the microscope had a classic usual interstitial pneumonia, a UIP pattern. And that gives you the idea why radiology doesn't completely, imaging doesn't completely replace tissue. We try to avoid having to obtain these biopsies, but sometimes they are necessary. And this is a case where in MDD would have been unclassifiable, and only until the biopsy was it definitely plays in a diagnostic category. So in the diagnostic process, hopefully briefly, you recapitulating what I've been saying, you go through the clinical assessment, and including the high resolution chest CT scan and the pulmonary function test, as I mentioned, and you bring all of that information to the multidisciplinary discussion group. If there is a clear exposure to agents known to cause hypersensitivity pneumonitis and the CT or the imaging is consistent with that disease, it is reasonable to establish that diagnosis without having to go through a biopsy. If the individual had features of collagen or connective tissue disorders, and that means both clinical and serological features, the serologies by themselves can be completely nonspecific. There has to be some clinical indication. And if the high resolution chest CT scan, again, is consistent with the many patterns of interstitial ILD that connective tissue disorders cause, then again, it is reasonable to assume that that is the type of ILD that we are faced. Unfortunately, a lot of cases we don't have a clear, etiological relationship. One thing that is missing from here is occupational exposures, of course. But if the chest CT imaging shows a UIP pattern, it is reasonable to diagnose interstitial pulmonary fibrosis if it is classic of that. If it is there is an exposure to an occupational agent, again, you would arrive at that diagnosis without necessarily obtaining tissue. But if that's not the case, and that's what these, if you have any of these exposures, but the imaging is not quite conclusive, or then it depends on whether you suspect that what may be going on could be infection, cancer, or sarcoidosis. Those are the three major indications to do bronchoscopy with bronchoalveolar lavage and transbronchial biopsy. And because the other option, if you don't suspect these three, is to go to a surgical biopsy or a cryo biopsy. And again, you need to bring the information again to the multidisciplinary discussion. Hopefully you will have identified the diagnosis, but if you don't, in the case of having this pathway where you had done bronchoscopy, you still can go to surgical biopsy and again go to the multidisciplinary. But in some cases, this corner here on the right, the lower part, leads you to some diseases that are unclassifiable. I want to spend at least some time discussing interstitial lung abnormalities. CTs are being done left and right in the general population, and a lot of incidental findings of interstitial fibrosis are identified. If they affect at least This is an arbitrary threshold of 5% of the volume of any lung zone. With any of these features that I mentioned before that are listed here, those are considered interstitial lung abnormalities when the individual doesn't have symptoms or lung function changes, either one of the two. And ILAs have been described in the World Trade Center workers. They may represent clinically under-recognized disease, and or they may progress to become ILDs, but only surveillance and time will tell. Many patients do not evolve in that manner, but there is a good proportion that may, and that's why they need the follow-up, the type of follow-up that the health program provides. When it is less than 5% of the lung volume, they are considered minimal and they are less often progressive in nature. And I have here some findings from a series, again, about 1,450 workers that had chest CT imaging, just to mention that issues like irregular linear opacities were found in about 13%, ground glass in about 8%, honeycombing in close to 1%. So you see where we have some of these ILAs, ILDs to follow, and that ILAs are more frequent than the ILDs for the most part. So, but all of them need follow-up as we can provide with our programs. Here we have a situation of some examples of those interstitial lung abnormalities that are occasionally identified, and they may sometimes alarm patients and sometimes their clinicians. And they are these small areas of ground glass of abnormality. This is a little bit of a subpleural area of ground glass with reticular abnormalities. You see that how it's minimal these findings are, but there is a little bit of honeycombing here, probably. So what I mean to say is that these are the type of ILAs that sometimes are identified incidentally, sometimes in the course of doing another investigation. We have seen it sometimes in abdominal CTs that reach the lower part of the lung and actually may see some of these findings just to they may be captured. On the other hand, there are a number of abnormalities that do not constitute ILAs. For example, next to osteophytes of the spine, you can find these fibrotic bands. Those are really not ILAs. And when they are unilateral, you tend not to, because these diseases are usually diffuse and bilateral. So these, for example, could have been a case of aspiration, like this example provided here, or sometimes smokers have these centrilobular nodules that relate to respiratory bronchiolitis. The importance of these ILAs is that they can progress over time. Is an individual in panel A at baseline where there are these findings here, this little bit of reticulation here, and 7 years later, look at how long it is, those lesions have progressed, and now it is approximately the same level, but you can see the progression also at these other location. So this is why we follow these individuals over time to see if they are going to develop the fibrosing disease. So this is a case with cancer treatment and where you see the progression. And in this case, there was a fusion that was after surgery for lung cancer. Because the radiologist's eyes may have some difficulties, this is a patient 5 years interval, and you see that it's almost perfectly normal. This was a smoker, and this is like 5 years later. The radiologist can try to quantitate, but these are still very mild findings. Computerized systems have been developed to do quantitative CT scan. The red here is normal. Green is centrilobular emphysema, because I said it was a smoker, and the interstitial abnormalities are here in blue. So the computers can help assist, and these are systems that are developing, that are completely accepted yet. This is an even more subtle case. There is again a 5-year interval between these two, and you can see that the quantitative systems are able to assist the radiologists with the quantitation of this progression, make it more obvious. So you have a number of risk factors for progression of ILAs. They are mentioned in the article, and like cigarette smoking, medication, radiation therapy, surgery, and some of the radiological factors can have features can be harbingers of the further progression. So ILA can be identified, confirmed radiologically if there are symptoms or lung functions. There could be a potentially clinically significant ILD. It's best to refer to a pulmonologist. And if the diagnosis is confirmed, of course, the treatment is implemented as accordingly. But if that's not the case, if the diagnosis from the pulmonologist is ILA or interstitial lung abnormality, or from the beginning you can tell that that's the case, a diagnosis is made, and one has to assess whether there are features that would increase the risk of progression, in which case you both do risk factor reduction and active monitoring with follow-up chest CT scans. If that's not the case, you still want to reduce the risk factors, but you reassess probably at longer intervals just to ensure that these changes are not progressing. So here, some of the, in the case of ILDs, the monitoring, these patients should be followed at 3 to 6 months. There's no ideal timing with assessment of symptoms, CT, assessing comorbidities, disease progression, and the comprehensive management should include a number of preventive measures that the non-specialist can implement, like vaccinations, smoking cessation, weight reduction, exercise, supplemental oxygen, pulmonary rehabilitation. Routine lung cancer screening, chest CT-based lung cancer screening is not recommended, even though the ILDs are risk factors for cancer. Lung cancer. Antifibrotic agents slow down the progression of fibrosis in ILDs. Immunosuppressive medications, contrary to past practices and common belief, they are reserved for ILDs where there is a predominant underlying inflammatory process, like the connective tissue disorders or hypersensitivity pneumonitis. Sarcoidosis also falls in that category. I won't go into the discussion of the treatments because it's already been mentioned in a way how we go. But the only curative treatment that we have right now is lung transplantation, and the optimal timing for evaluation kind of varies. It is a little bit earlier in cases of diagnosis of IPF or NSIP, or when the forced viral capacity has reduced to below 80% and the DLCO, the diffusion capacity, is in the 40% range, or if the individual clearly is desaturating or it needs oxygen supplementation or has not responded to pharmacotherapy, they really should be seen early by the lung transplant team. On the occupational side, we of course worry about disability assessment, workers' compensation, filing, etc. And although I wanted to drive this message home that although the treatment of ILDs requires a subspecialized team, general practitioners and non-subspecialized pulmonologists can contribute a great deal of support to the patient and to the adequate treatment of these patients. I realized that I ran out of time, so I won't have time to discuss cases unless I'm told the opposite. So I would, but I wanted to ensure that I have allow time for questions up to now.
Dr. Calvert, did you want to go into questions or have one of the case presentations?
Dr. Delahose, can you spend maybe 5 minutes on case presentations?
try 3. Okay, case
Okay,
presentation.
thank you.
So I have 2 cases and I present them together. Both of them, I saw them, one of them in 2007, 2009, 2 of the first cases of interstitial lung disease that I got to see. I actually followed them until they both underwent lung transplant, single lung transplant in 2014. So, and both of them had non-specific interstitial pneumonitis. At that time, given our situation and a little bit of confusing picture, etc., we did opt for a surgical lung biopsy, doing video-assisted thoracoscopic biopsy. We had an excellent surgeon at that. We have a very good thoracic surgery service here, so this was done very uneventfully. Both of them were diagnosed with NSIP, and I followed them until their lung transplant. So this is the first case, and this was a nurse that had the unique situation of not only being a responder, she was in an ambulance helping people in the at the disaster site, but she also lived in downtown Manhattan, so she also was what would be called a survivor in the cohort. And you can see the NSIP pattern where there's some reticulation, but there's a fair amount of ground glass density and reticular reticulations I mentioned, and linear densities, and what may be the beginning of honeycombing, but very questionable probably here. So just to give you an example. But her biopsy show NSIP, as I mentioned, with the thickened interstitial wall. And the other case was a 47-year-old former police officer, worked at the World Trade Center, recent former smoker, and he was early on, I'm sorry, at the site. He was being followed in Staten Island, no, sorry, in Long Island. And for a number of years, this was his lung function, his forced vital capacity was at about 5 liters. And this is in 2007 when he started, in 2008, it started decreasing. This is for 1 year, this is actually a large decrease, almost a liter. And then continue doing that until he reduced almost by 50%. And this is what our surveillance programs can help identify and monitor. And then in 2014, as I mentioned, in the summer of 2014, and there were lung transplant, a little bit of a rocky postoperative course, but he eventually came up to almost close to the 2007 level. And then he was followed, but he again decreased in 2019. At that point, I didn't plot it here, but the FEV1 plunge even more than the FVC, so he became obstructed. And that's a very clear sign of transplant rejection. Rejection is usually an obstructive phenomenon as a bronchiolitis. So, and that's where right now where he is at. He is receiving some treatment to try to fight his rejection, and he's more or less holding on, but that already happened. So both of them NSIP, and that's his CT scan. This is the transplanted lung. This was a post. I wasn't able to get a hold of a pre, but the left lung shows us how the pre-transplant lung looked. And this is the post-transplanted, the post-transplanted right lung. So this is the case, and we send both of these patients to pulmonary rehab, vaccinations. They were very good at that. The nurse was a non-smoker. The police officer had stopped almost immediately after he started declining lung function. And the first case is deceased, unfortunately. And the second one still alive. So those are my 2 cases that I just use as examples of 2 of the World Trade Center workers and the type of work that we do through our surveillance and preventive care.
Thank you, Dr. De La Hoz. That transitions very well into our first question. Are there any differences in the ILDs that are observed in responders compared to survivors?
We really have not seen any of that. Not really. They have been practically the same types of disease. The mineralogy that I described for my two cases here was actually published in a survivor case series. So mostly silicates, etc. There is some disagreement as to whether there were some subtypes of asbestos fibers or not, but we definitely in our cases have not seen it at all. So no, there doesn't seem to be a difference, and there doesn't seem to be a difference in turn with the general population. We have not seen that.
Thank you. The next question we have, why did you choose a clinical practice guideline produced by the Canadian Thoracic Society? Do you know if the American Thoracic Society has a clinical practice guideline for ILDs?
Oh, what happened with the American Thoracic Society guidelines is that they are disease specific. So they have one for IPF. They have one for hypersensitivity pneumonitis. They have one, and first of all, they only cover a few, maybe 5 or 6 of the, as I said, more than 200 diseases that there are. And so that's problematic. And some of those guidelines, I'm thinking hypersensitive pneumonitis was updated in 2020, if I'm correct, and IPF probably a little bit more recently, but some of the other are very old. So they didn't meet the criteria for what we would have considered ideal for this series. But first and foremost, the Canadian guidelines cover all the fibrosing ILDs. And that was very important because I thought that it was a perspective that the clinicians in the clinical centers and the NPN needed to take into account when facing a patient with some of these changes.
Thank you. Our next question, in a patient with suspected fibrotic ILD who needs lung sampling, the person asking the question believes you mentioned a preference for surgical lung biopsy. Why is that preferred over a transbronchial biopsy?
Oh, fortunately, I had a chance to show that in the flow diagram for the diagnosis that came from that Canadian thing. Guideline. And the reason is that transbronchial biopsies or and bronchoscopic procedures are most effective when it is cancer, infection, or sarcoidosis as a primary or a strong suspicion. So when those are strong considerations, that's when bronchoscopic procedures have a higher yield. Now, through bronchoscopy these days, you can do cryobiopsies. And I didn't emphasize that too much because it is not a procedure that is available in not even some of the major academic centers, but they are available and they produce a larger sample. But unfortunately, it's not available in many centers. So the multidisciplinary discussion group has to decide whether it is necessary to go through a surgical lung biopsy. So that is the reason we try to avoid surgical lung biopsies. That's why we go through all of those discussions to try to fit a pattern and try to arrive at a diagnosis. But bronchoscopic procedures have limited diagnostic yields unless cancer, sarcoid, or infection is part of the picture.
Thank you. I think we have one more question that we have time for. Are there any differences in the type of ILD developed for acute high World Trade Center exposure, that is a few days within 9/11, versus chronic long-term World Trade Center exposures from workers who were working months later?
We haven't been able to detect such difference. I would say at the beginning in 2007 and 9, I'm glad that I was able to present my personal first two cases. So that's, I thought that NSIP was going to predominate, but NSIP is known to happen in individuals a little bit younger than UIP and IPF. So as time has gone by, we are seeing more IPF. So I think it is we have not been able to tease out any differences by occupational group, by intensity of exposure, nature of exposure. As I said, the survivors and the responders have very similar diseases. So no, so far, no, we haven't been able to discern any of that, but more work needs to be done. And we have accrued more cases, and we'll see if we have a better answer to your very good question.
Wonderful. Thank you very much for your presentation, Dr. De La Hoz. At this point, I'm going to transfer it back to Dr. Calvert for his final remarks.
Thank you, Ann. And thank you, Dr. De La Hoz, for a very interesting presentation. We had a very good audience. Over 100 people are in attendance. So thank you also to the audience. So now let me explain how to get your continuing education credits. So I recommend that you do a print screen of the slide, because there's some information on here that you're going to need to register to get the credits. So what you'll need to do is go to the website that's near the top of the slide, the www.train.org. If you're not already registered in that site, you'll need to register. And then once you're in that site, you're registered, you're logged in, you'll need to find this course. And I think the simplest way to find it would be to type in the WC 4740. And that will bring up all of the live courses that are still available for CE credits. Keep in mind that for the live courses, the CE credits are available only for 30 days. So only for this course, this webinar, the CE credits will be available only till about the end of March. So if you type in WC 4740, I think there's actually currently 3 of our webinars that are still available for CE credit. And if you just want to pull up this one webinar, you can do the WC 4740 and then dash the date, 02/29/24. And then once you select that course and register for it, it's going to ask you for a registration code. So the registration code is WTCHP. And you need that code only for the live webinar. If you're watching the recording, to find the recordings, you would search on WD, not WC, but WD 4740. Then once you're registered and you're ready to take the post-test, there'll be 4 post-test questions. You need to answer at least 3 of those correctly. You'll get 2 opportunities, 2 chances to answer at least 3 of them correctly. And then after that, you'll be asked to evaluate the webinar, and then hopefully you'll successfully get your CE credits. And then one more slide. So our next webinar is going to be in 2 weeks on March 14th, again at noon. And it'll be an encore performance from today's speaker, Dr. De La Hoz, who will be speaking on the diagnosis and treatment of chronic obstructive pulmonary disease, COPD. So we're excited and look forward to seeing all of you at that webinar in 2 weeks. So thank you very much again for attending, and thank you, Dr. De La Hoz and Ann and Kiana for making this webinar such a success. Hope everybody has a wonderful rest of the day.